This week on the Backtable podcast.
The art of medicine is not perfect. We're doing our best. And really, mastering this art of communication is key. And it's ironic we're having this discussion. I mean, I'm a surgeon, right? If you ask 100 doctors who has the worst communication, 99 of them will say surgeons.
And what happens in surgical training, Ruchi, that makes surgeons such buttheads? What do you guys do?
They break us, okay? They just break us.
I mean, it's SEAL training. Do they throw you in the water or what happens?
Oh, they sure do. They sure do. I can't even talk about my surgical training, okay, on this podcast. It'll go out to too many people. No, I'm kidding. Listen, surgical training is intense. It is hard, but it prepares you for worst case scenarios. And when I'm doing surgery and there is a hole in someone's aorta, I need to be able to be absolutely 100% prepared to respond quickly, swiftly, and to make sure that we, avoid an adverse outcome. That's the point of surgical training.
Hey, everybody. Welcome to another episode of Backtable Industry. I'm Anish.
I'm Ruchi.
And we're your hosts. And Ruchi, I guess tell everybody a little bit about yourself before we get started.
Yeah, of course. I have an interesting role at my healthcare system. Clinically, I am a urologic oncologist, focusing mostly on prostate, kidney, bladder cancer. I operate 1.5 days a week. I see patients in clinic once a week. And then during the remainder of my time working at a large academic healthcare system in Nashville, Tennessee, I am the director for specialty value-based care programs.
And I'm an entrepreneur and the founder of Backtable, and I guess a self-professed critical thinker. And so I read this article the other day, Ruchi, that was in the Wall Street Journal. And they were talking about, the topic was why we don't trust doctors like we used to. Patients often feel ignored and complain about disjointed care and a lack of communication. That was the title and the subtitle. And it caught my eye for a couple of reasons. But I'm curious, did you see this article?
I sure did. And like you, I think it was quite an attention grabber with the headline. But if you dig in, there's some stuff there that I think is worth getting into.
So what stood out to you? Or maybe I'll summarize it. Let me summarize it.
Yeah, I was going to say, why don't you give a recap for the audience and then I'll sort of give you my thoughts.
So it opens with a physician who the reporter quotes, as a pediatrician actually saying, some relatives no longer seek her medical advice. Her adult daughters often turn to TikTok and Google to research conditions. And she says it's disconcerting, but not necessarily surprising because people are more wary now than they used to be of a healthcare system that is supposed to make them feel better, but instead leaves them stressed and frustrated. So she goes on to talk about a little bit of this and how it's unfolding with what people are, how people are viewing their docs versus how they used to, I guess. And overall, I'm not sure if she took a strong position. She was just reporting on there being instances of people not trusting their doctors, I guess, quote unquote, like they used to. Is that a fair summary?
I think so. And it's not the first time that we've heard this. I think whether you talk to doctors, whether you talk to patients, I think you hear a lot of the same themes. Medicine is not what it used to be for folks who are in healthcare treating patients. And at the same time, the experience of getting care is not the same as it used to be.
So do you see some of this? I guess you're relatively new treating patients, but I mean, sort of not really, right? You've been treating them throughout medical school and residency in a sense, right?
Yeah, medical school, residency, fellowship. I had a little bit of exposure even before medical school in a hospital. And so, I mean, 2+ decades of seeing this. Lots of reflections, a lot has changed. Let me give my perspective first as a physician, and then I'll sort of pivot to, my experiences as a patient, because I see doctors too. I think a lot of this goes back to the fact that the demands of a career in medicine are changing, right? We talked about this before. As physicians get paid less. Medicare reimbursement is actually declining relative to inflation and relative to payments for other aspects of the healthcare system. Physicians are generally getting paid less. They are required to see more patients. There's a trade-off. You get paid less per patient, so what do? You see more patients. For those of us who are employed, we're getting more and more pressure to meet whether it's RVU goals or whether it's patient visit goals. We got to squeeze more patients in. There's only 15 minutes for each new patient slot. What does that mean? There's less time. There's less time to dig into each specific aspect of a patient's visit. And you're rushed. You need to document. You're thinking about all the other administrative burdens. Whereas, I think several decades ago, physicians were not seeing as many patients per day as they are now. And so you have more time. And, I can't say this from a personal perspective, but I'll reference what a lot of my mentors have told me in the past. It's getting harder and harder to be a physician because we are getting more advanced in the number of treatments we can offer patients. Our understanding of diseases, continues to evolve and deepen, and there's just a lot more to cover. So I think that's a part of it too. Now, I don't want to, gloss over the fact that I think patients are very different now than they were several decades ago. Look at all of the information that's on our fingertips. I think you've said this to me before. If you're feeling sick, the first thing you used to do is pick up the phone and make a doctor's appointment. Now, if you're starting to feel symptoms, the first thing you do is you pick up your phone and you Google, like, I have a cough and I have a fever. What could this be? Right? So patients themselves are getting access to more and more information, which, for the record, I think in general is a great thing. I think that's a great thing. I think patients taking accountability, ownership, and we're empowering patients to take charge of their health. I am all for that. But the tricky thing is, who is vetting what information is out there? There's a lot out there on TikTok, Instagram, X, Facebook that may not be verified to be medically accurate. So it's a double-edged sword. I think a lot of what they're reading may not be 100% verified, accurate, vetted by physicians, et cetera.
So in the article, to carry on this, in the article, she quoted, I think, a patient who either she or her husband had a somewhat complex condition, and they were going to see multiple doctors, and they were getting different, answers from different physicians. It was hard to navigate. And then there was another patient who I think at first was told, your symptoms are in your head. And then went and saw another physician who diagnosed her, and then she got passed around to a third, I think, and she was hoping that physician would stay. And to back up for a second, I'll offer some of my thoughts when I was reading the article, or that, this is like, there's this purported decline in trust of physicians, okay? Which implies that it was definitely there to begin with, or that it should have been there in the first place. And I was doing a little reading, had a conversation with ChatGPT about this. So rewind a couple hundred years, it wasn't like that. Most doctors, maybe 300-ish years, it was kind of viewed as quacks because they're often offering these healing powers, and there was no real regulation. And it's like, this doctor says, I'll live forever. And then they're selling, the term escapes me, but anyway, they're selling everything so that you can live longer or be healed or whatever. Then science really advances, antibiotics are offered essentially, and hospitals become centers of medical excellence rather than places that people die. And doctors now are kind of regarded as almost, a step away from God. Like, you can save my life. We've talked about this before. I got a lot of doctors in the family. And I think what happens with my perspective is that what happened with some of this is that people placed too much trust perhaps in doctors. Like, oh, I'll just get sick and they can save my life because that's what happened to my cousin or my friend or whatever. Which I think is also in some cases just, I'm not going to say coincidence, because I'm not saying like doctors are getting lucky or something like that. It's like you study these things so you know how to practice them, and then you fix somebody that had that problem. And then it seems like it doesn't work quite as cleanly when somebody's quote unquote problem doesn't fit exactly the circumstance that not only med school and training, but like the entire system was designed to take care of.
Let me just tell you, that's why it's the art of medicine, right? That's why it really is an art. No two patients are alike. No patient entirely fits a clinical pathway. Clinical pathways, clinical guidelines, they're there to guide us, to make sure that we're providing high quality care. But in reality, it's not always exactly per the algorithm, right? You're referencing several situations where patients had pretty complex or rare issues. And that is why we have centers of excellence. That's why we have tertiary care centers, quaternary care centers. I totally agree with your point, though, that you cannot wholeheartedly place trust in someone saving your life if you have a healthcare condition, right? I think the pendulum, perhaps maybe in some cases, swung too far to one side. There's no question. There's mistrust in institutions. Forget about medicine. There's mistrust in institutions in general. That's the way society has gone. Medicine is one of those institutions. We're seeing it there too. We're seeing people question the validity and the science behind vaccines or certain medications. Or, I often hear, I'm a cancer surgeon. So I often hear people say, well, if Big Pharma wanted to cure cancer, they would have done it already. There's no way we wouldn't have had that science. They're just keeping it going so they can make money. I think that's inherent mistrust in all of our systems. And listen, the practice of medicine is not perfect. Look at Tuskegee. We have a dark history of exploiting vulnerable populations and not practicing ethically. There's no question about that. So I think, in my opinion, the key is transparency. The key is encouraging patients to take ownership, to take accountability, and to do their own research. I think when you're in doctor circles, when you hear that term, like do your own research, it's really looked down upon, and it's something that causes a lot of discomfort for physicians. But I think what we should do is empower our patients to do their own research, to learn, but use reliable sources, right? I mean, there are some great physicians out there on social media who are providing trustworthy information. There are Facebook groups out there that patients can use to connect with one another. And, there's going to be certain quality of life perspectives that I'm not going to understand. I can treat a disease for 100 years. If I'm not experiencing that disease, I really may not be able to put myself in my patient's shoes. So, I think that trust that you're saying, there's a happy medium between trusting your physician to do what's best and also taking ownership and understanding that you have to be an active participant in your health as well.
Yeah, that's right. You have to actively, almost commandeer it, I would say, but absolutely a physician, especially a specialist, helping you with a certain type of disease can be extraordinarily useful in that.
Yeah.
In a variety of ways. It goes back to what you said about the specialization. I think there was maybe everything has gotten so much more specialized and there's just so much more knowledge that you can't just broadly apply the term doctor, really. You can, but it's almost like, I joke because I have a brother who's like a world-class surgeon and, is a leader in his field. And certainly if I had to have surgery or, if I was in like a trauma situation, be like, I need him, I want my brother to help me look out for this. But I remember, I'm also a competitive tennis player. One time I was talking to him about, something about like cramping and the way that electrolytes affect cramping. I had read all these books and I wanted to talk about it with him. And he's giving me his opinion. And I was like, remind me not to talk about this with you. You actually don't know what you're talking about, which is okay because you probably don't care.
But that's right. Like I tell patients all the time, like I know a whole lot about one very small sliver. Like I know I can go real deep in urologic oncology and surgical techniques and your options. But if you ask me about the cyst on your eye, I'm going to be like, dude, I have no clue. I can't help you, right? That you're right. That's part of the double-edged sword of the medical field and everyone really hyper specializing. And you referenced this earlier. The person was really one of the people who was quoted in that article was very frustrated because they were getting passed around from physician to physician. But particularly at like a large academic medical center like the one I work in, even within the field of urologic cancer surgery, each of my partners has a pretty narrow focus. And that can be tough because a patient goes online and searches for a doctor they like, and they're ready to go talk about their bladder cancer with that doctor. And then that doctor's like, I got to send you to someone else. I don't really do bladder cancer. I only do kidney cancer. That's frustrating. Patient probably drove. Often they drive 3 hours to come downtown Nashville to see someone. I mean, is that not going to erode trust in our medical system? Of course it is. So these are all the things that physicians have to remember when they are on the other side of a patient maybe being frustrated. Let's remind ourselves probably the 100 things that happened to get that person to this point and have this sort of reaction.
I think that's very, what's the right word? Maybe generous of you to remind physicians to remember that. That's great. I actually think that article is, in a way, it's like contributing to the problem in a sense, because it implies that anybody except for the patient should have responsibility for that. Like, in my opinion, I mean, look, I hope I don't, I'm sure I will, but I hope I don't find myself in that situation. And the probabilities are that I will, like everybody out there. But when that happens, it's not my doctor's, it may be their job to try to cure me, but it's not their responsibility. It's my responsibility to cure me, or to do whatever I can to get cured. And it's like, if the doc is like, well, I don't do this, it's got to be on me to be like, shoot, let me go figure out who does. Let me go figure out what I got to do, or what expert I got to find who can have a shot at curing me. That's on me, not on any doctor or any hospital system or insurance. I mean, that's on nobody but me, in my opinion.
Yeah. Well, let's dig into that a little more. Tell me more about why you feel that way.
How could it be anybody? If I get sick, how could it be? I mean, those are the laws of nature. Like, I mean, we live longer, and so now more diseases can get us because old age isn't, or whatever, or, we're smoking less, so we could live longer, so less of those are getting us. So, I mean, cancer has been around since human beings have been around, basically. So this is going to come out the wrong way, so help me with this. And I have had family members who've had this, so like, it's absolutely awful to have cancer, but it's not like unfair in the sense that somebody caused it. Like, unless there's some like company that caused it or something like that, those are exceptions. But like, even then, when it happens, whose responsibility is it to do something about it?
Yeah, I hear you. I hear you.
Ahead.
I think
you disagree.
I think, well, like most things, we disagree, right? That's the beauty of this. Varying perspectives. I don't disagree fully. I think that there are a lot of people who, again, can have the ability to take ownership for themselves and their health. And then I think there's a lot of different people in this country and in this world who have varying degrees of understanding, education, ability to do the sort of research that you're describing. And while I think ideal state is everyone empowers and takes ownership of their health, I don't want to be paternalistic when I say this, but there's a lot of people who are at a disadvantage due to circumstances outside of their control, and they maybe can't take that sort of ownership of their health. We talk a lot about social determinants of health. That's one aspect of this. So again, I think there's sort of a little bit of a happy medium. I do think that we can't expect people, like, if we have a patient who is diagnosed with lung cancer and refuses to give up smoking, but still shows up to the doctor's office demanding a cure, demanding all things be done. And then when the physician says, listen, you really got to stop smoking, that's the number one modifiable risk factor we can, adjust here to help us get a better outcome. Yeah, I mean, of course, it's, you can't expect a miracle when you're not willing to put in the effort too. But I think it's really tough. And I think most doctors go into medicine not for the money, not for the glory, not for anything, but other than the fact that they really want to help people. Otherwise you wouldn't like do all this training and all of that. And so that's my gut reaction when I hear you say that. I think, like, of course we want you to take charge of your health. That is ideal. And I think as people understand and get more educated and again, educational, like niche educational material regarding medicine is more accessible with things like the internet, AI, all these websites, this podcast, for example, all of these things help make things more accessible for patients. At the same time, it's a doctor-patient relationship. We're in this together. The burden doesn't fall on either one of us. We go on this journey together.
Yeah, that's how it ideally works. But I think, let me go back. I mean, I think where we, oddly enough, we agree and we disagree, because it's not that I think it's right or wrong. I'm not trying to say that everybody should take responsibility and that nobody else should. I just don't even think it's possible. Like, I think it's like a fact almost. I mean, my opinion, but like, it's just like the way that it is that you're responsible for yourself. No, like, I hear you on different levels of advantage and insight into the problem. Totally agree. Not everybody's going to have the same ability to navigate it. And it is a wonderful thing to offer more help to those who can navigate it. I mean, like, I would never stand in the way of that or disagree with that. I just think that it fundamentally, you can't change the fact that it is each individual's responsibility. Like, if I get sick, it's my problem. My wife's going to consider it to be her problem. Some of my relatives will be consider it to be their problem, but that's, it's still, anyway, for whatever it's worth.
I agree with that. I'm curious, this article talks a lot about communication. So tell me about your experiences as a patient. What have you found that's worked well in doctors who communicate with you well, given that you have this outlook of like really taking ownership and feeling that burden for yourself? And then tell me about what hasn't worked well.
Good question. I've gone through a number of primary care doctors in the beginning, like when I was, probably 10, 15 years ago, just like not even caring. And, more recently being a more educated patient, hopefully. And that is somewhere between like easier and more of a pain in the ass to my doctor.
Yes.
Curious what he would say. But as an example, I mean, so I read the Peter Attia book, Outlive. Did you read it, or are you familiar?
I didn't read it, but I have heard.
You're familiar?
Yes, very
so
familiar.
Like a lot of people, I think my reaction's probably typical, is my guess. So I go and I read this, and Attia's talking about, quick summary, basically the 4 horsemen of death. So cancer, heart attack, diabetes, and cognitive decline, basically, or neurodegenerative disorders, right? So it talks about what you can and can't do. And I'm really looking here at, really nothing you can do about cognitive decline, neurodegenerative disorders. Not a ton you can do about cancer except for not smoke and basically exercise. And then there's cardiovascular disease and then diabetes. So I'm like, all right, I should change my habits a bit, let's see what I can do about eating to fix, risks of diabetes. And then let's look at cardiovascular disease. I'm a South Asian male. Okay, I got some slight hereditary risk of this. I'm like, okay, so I'm thinking about all this where I hadn't before, because I've been prescribed the regular panel of tests that says you don't have any risks, basically, or you don't have much to worry about. Whereas this doctor trained, Johns Hopkins, like definitely is way outside of the norm, but he's like, hey, I don't agree with that. I actually think you got plenty of risk that you could do something about, but you got plenty of risk that, whatever the American Heart Association and everybody else doesn't agree with. So now I'm like, shoot, I better think about this for myself, because my doctor's not necessarily going to help me if I don't go and like push for myself. So I'll tell you about the rest of it, but let me pause there. I mean, that's I think it occurred to me when reading that book. Like, I've now got information, and if I don't act on it, nobody's going to act on it for me, because the world hasn't caught up to this. But before we get into the rest of it, like, what do you think of that?
That's great, right? I hope that all my patients have that outlook, because again, without buy-in, it's hard to have a successful outcome. And so I think that's awesome. But again, how many people have read that book? How many people have that level of insight? It's tough. I could tell you, even then, a lot of people who do their own level of research and come to an appointment prepared, I think sometimes the tricky thing is their mind could be made up. And that's another thing, is when somebody's mind is made up and you're perhaps offering an alternative option for them. For example, I have patients who come see me who are, dead set on surgery. And I say, hey, what about radiation? Here are the reasons why I think radiation may be a good option for you. And sometimes it catches people off guard, and they've sort of made up their mind, and that can be tough too. So I think I know you well, and I know you have an open mind. And so I know that's going to be less of an issue for you. But I think sometimes when patients are going through something scary, a life-altering diagnosis, it can be really easy to like set down a certain path and not consider alternative options.
So let's dig into that. I mean, I'm guessing that at some point, somebody's come to you as a patient with a certain condition, and then they've maybe done some homework, talked to a family member, another physician, read something online, is like, okay, I'm ready to cut the tumor out, just crude talk here, but like, okay, let's cut it out. And you're like, well, it doesn't quite work that way, and you're saying it's kind of challenging because they've read some things that sound similar, without having all of the context around the decision, basically.
That's right.
And they're
That's
saying, I
right.
want to make that same decision.
Yeah.
And your job is, in a sense, to combat all that other information and help them, because you're trying to take care of them. And so how do you experience that? How do you think about that? Like, how do you even go about that?
Well, my job, like you said, is to help guide them make a decision. There's no such thing as a right or wrong decision, no matter how much I may think there is, or physicians may think they're right versus someone's wrong. There's no right or wrong. There's no black and white. It's all shades of gray. What is the patient's quality of life? What are their priorities? What are their goals? You know, these are all things that we constantly have to be thinking about. And just because their goal may not be your goal, that doesn't mean they're wrong. And so what I try to do is actually use, there's amazing patient advocacy networks out there and patient advocacy groups that actually connect patients with one another. For example, you know, there's a great organization called Beacon. It's the Bladder Cancer Advocacy Network. When a patient's diagnosed with bladder cancer and they're considering various options or various urinary diversions, you can actually get in touch with a patient who's been through that experience before. I love that. Like, why don't we do more of that? No one's going to understand what you're going through more than someone else who's gone through it. And so I try to provide them patient-centered educational materials. The younger people, sometimes they like to follow accounts on social media. And so I try to educate myself. Part of my homework is what sources are available publicly on social media, on the internet. You know, if they like books, I can offer them suggestions on books or websites. So the part of that is my burden. But I have to remind myself too, I'm not perfect. I sometimes get frustrated and it's a journey. It's a journey that me and the patient are going on together. And I try to be transparent too. And I try to like really say, level with me. Here's what my thought process is.
Yep.
I pause. I say, what do you think? You know, I acknowledge. The first thing I'll do, I threw a lot of information at you here. I'm going to pause before we go on. Tell me what you're thinking. And it gives them a minute to process and teach back what they heard.
So I'm curious, either, you know, as a urologist or maybe as a uro-oncologist, urological oncologist, did you get trained at all in that conversation?
I'd like to say that they tried. You know, we have these things called OSCEs where we have to counsel patients. They feel fake, and you go through the script and you study what you're supposed to say and what you're not supposed to say. But nothing has trained me more than like real life experience. And I tell my trainees all the time, you're not going to know for sure how you handle those situations until it's your license on the line. It's your patient. The buck stops with you. It's your responsibility. Because I did that in training, but there was always an attending physician who was able to step in and you know, there was a safety blanket.
When you say your license on the line and your responsibility, like, tell me more about that. Because in a scenario like you just mentioned, patient says, I want to get surgery, and you're like, ooh, I don't know if that's the best option. Whose responsibility is it? Like, do you walk around with that responsibility? Should you walk around with that responsibility?
If I'm taking the patient for surgery, it is 120% my responsibility. You're asking if I'm recommending surgery or if the patient's considering surgery, who's responsible? It's a good question. I mean, I'd have to ask the lawyers, right? But if a patient comes to me to want to have surgery, I make an alternative recommendation and they have a poor outcome from that other option like radiation. I don't know the degree of responsibility, but I can tell you I feel responsible. I mean, whether or not I'm operating on a person, even if I'm seeing them in general, I tend to take responsibility. I mean, I think any human, any reasonable, rational, caring human would. You're providing a recommendation for someone in their time of need based on the knowledge that you know. But I sense that you're going to say, well, it's the patient's decision.
No. It isn't. I'm actually asking because, so we'll go back to me for a second. And then, after reading Outlive, I go to my doc and I'm like, all right. And I had researched all these concierge docs who practice like the Peter Attia medicine. I was like, I'm just going to go to a primary care doc in my group here. Let's just see what happens, you know? And this guy, to his credit, he's just like young guy, thoughtful, had a conversation with me. I'm like, all right, so, hey, listen, I read this and just tell me, like, why am I not on statin right now? I mean, Attia says it's going to bring down my risk, and that the guidelines aren't really caught up with this. And there's a decent chance that the guidelines are going to change to this because there's a lot of evidence. Now, we don't know what's going to happen, but there's at least a non-zero chance that in 10 years or 20, the guidelines are going to reflect what this says. in which case we'd like to turn back the clock and say, do this. He's like, you make an interesting point. Why not be on a statin? Your tests don't show that you have the risk for that. I'm like, okay, well, why don't you just put me on one? He's like, well,
Well, it's his license on the line, right? Let's say you're on an unindicated medication and you have an adverse reaction. You get the muscle cramping, that whatever. That is his responsibility. He wrote the prescription.
right. And that's why I was asking, because I was running through that in my head. Like, what if I did have I'm not the litigious type, but I suppose, I could be.
Exactly.
Right? If
Exactly.
if I was like, right, and the evidence would then say, why did you do that? And he's sort of taking a risk in a way, because in the end he was like, okay, well, we got the calcium score and everything was good, but he's like, look, it's really not what the book calls for, but I could make a case that you could be on it. And obviously this is different. I'm a different case, but to go back to what you're talking about is like, I guess why. So that's a scenario where I'm asking him to do something that he's like, I don't know if we should do this, basically, because he can't really know. I mean, I would say he can't know.
Yeah, and he could make the case either way. And the best practices there say document. It's shared decision making. He talks to you about the risks and benefits. You understand the risks and benefits, and you came in. You made a share. You experienced shared decision making and landed on the fact that you either were or weren't going to start a statin. I think he could go either way. And that's where documentation and really making sure you talk through risk benefits and all of that can go a long way. But that you need good communication for that. And in general, communication allows for a healthy therapeutic relationship and will hopefully assuage some of that fear of practicing defensive medicine or practicing medicine just to avoid getting sued. That is a fear for a lot of people. I think, again, my naive, optimistic sort of look is that we are all just trying to help people. The art of medicine is not perfect. We're doing our best. And really, like, mastering this art of communication is key. And it's ironic we're having this discussion. I mean, I'm a surgeon, right? Like, if you ask 100 doctors who has the worst communication, 99 of them will say surgeons.
And what happens in surgical training, Ruchi, that makes surgeons such buttheads? What do you guys do?
They break us, okay? They just break us.
I mean, it's like SEAL training. Do they throw you in the water, or like what happens?
They sure do. They sure do. I can't even talk about my surgical training, okay, on this podcast. It'll go out to too many people. No, I'm kidding. Listen, surgical training is intense. It is hard, but it prepares you for worst case scenarios. And like when I'm doing surgery and there is a hole in someone's aorta, like I need to be able to be absolutely 100% prepared to respond quickly, swiftly, and to make sure that we, avoid an adverse outcome. That's the point of surgical training.
Quick detour while we're here. So tell me about being a female surgical trainee.
No. This needs its own episode. This needs its own episode. I can't even go down that rabbit hole right now. Oh, my God. Also, you might as well just record a therapy. No, I'm kidding. But no, it's hard. But part of that, you bring up this idea of a female surgical resident or female surgeon. I do think, and the evidence does show that our patients at least think we have superior communication skills. That's not me. That's the evidence. There are papers out there to support that. So of course, I think maybe I'm bringing a little bit of a unique perspective there, but we need more of it in all of medicine, not just in surgery, in all of medicine.
So to run this back, patient comes and says, I want to treat this cancer in, making it up, my bladder with surgery, doc. And you're like, oh, okay. I don't think that's a good idea. And tell me if this is right. So you now have a couple of concerns. Like, one, for the patient, I don't think you should do this. And this is potentially a problem for you. And you're going to end up with, you have the chance of side effects or whatever complications that are really not necessary. And two, if not only that, but if I take you down this path, I am responsible.
Correct.
And even now in something like that, I would suspect it's much more severe than like me demanding a statin. Even if it is quote unquote shared decision making, that's probably harder to. Or I mean, at some point, are you like, hey, I can't do this for you. Maybe somebody else can, but I can't do
And
this for you.
I will refer patients. And I will refer patients for a second opinion. And, and that's okay. That's knowing what you feel comfortable with and knowing where to draw the line. And I think it's a really slippery slope in surgery when you are doing surgery that perhaps your gut is telling you not to. We talk about that a lot in what we call M&M. It's our sort of postmortem conference to analyze complications. And so, if my gut is telling me no and the patient wants to proceed, then I will offer them a second opinion. That's important. They are following what their true north is and what their gut is telling them and what their priorities are. And I respect that and I want to empower them. And if I can't be the one to bring them to that endpoint, I'm happy to refer them to someone else who may be able to. That's okay. I think most patients actually appreciate when I am transparent. Transparency is an important aspect of communication.
Yeah. So, I guess that's what is different here, I would say, is that the liabilities are different. For me as a patient, oddly enough, it's easy for me to be somewhat flippant, to be like, oh, I want to try this. I want to try that. I want to do this thing. But other than my life, I don't have any other liability at risk.
That's right. That's right. And I think you are correct. But, to flip it back to this article, I think, again, physicians tend to get frustrated when they hear this term, I did my own research, or I read up on this first, and it generates like a sigh. Okay, here we go. But I think we can do better, and we can try to empower our patients with reliable information, understanding the way the world is going. The mistrust in medicine is no different from the mistrusts in institutions and, banking systems that have led to the rise of so many people, investing in things like cryptocurrency, or, this lack of trust with the government even, and people questioning on both sides, certain government agencies or the role of the police, or, I can go on and on and on. Medicine is not immune to this.
Well, like you said, people are getting more informed, for better or for worse. I think it's for better, generally. Now, sometimes
Absolutely.
The information isn't right, which is a problem. But it does seem like with more AI tools synthesizing that for you, then it's easier for anybody to be more intelligent than previously.
Yes, that's right. And I think that the onus is on us to recognize where medicine is headed. And instead of being reactive and, dealing with the fact that there's a lot of misinformation out there, we have a real opportunity to be proactive and adjust how we counsel patients, really hone in on that doctor-patient relationship. Sounds like your physician did when you went to see them, your primary care physician that you're referencing. That's the goal. And I do think some of the younger generation understands that. We ourselves, again, I said I'm a patient too, and I will look up what I think is happening to me before I go to the physician. So I try to remember that when patients come into my own office, having done their own reading. And we just got to roll with the punches and keep up and adapt and be nimble.
Well, it's a good place to leave it, I suppose. And I think as patients, we got to do our homework, but remember, what's the right way to say it? You got to let the doctor do their job too.
That's right.
Because as an example, I came out of there thinking, all right, I can't demand to be placed on a statin. It's not going to work that way. It's not going to go down. But maybe we can, like you said, arrive at this shared conclusion, which he's supportive of. And I'm recognizing that he has a lot of experience and background that I don't have, because it's not all in the one book I read this week.
Yeah. Yeah, there's a reason that we're still around, and we can't just have, Chat GPT or DeepSeek or Gemini or whatever take our job right away. It's not there yet. Medicine is still an art. The doctor-patient relationship, some people may roll their eyes when I say this, but it's sacred.
Which is cool. There's not a lot of things like that.
Yeah, true.
Well, anyway, it's been a good conversation, Ruchi.
Always great to chat with you.
Yeah, same. Maybe in the future we'll have to get into this female surgical trainee situation here.
Yeah. Give me 4 hours, No, I'm kidding. That'll definitely be a topic for a future episode, so stay tuned.
All right. Well, as always, this has been Backtable Industry. I'm Anish.
I'm Ruchi.
And we'll see you next time. All right, guys, thanks so much for listening. If you haven't already, be sure to follow and subscribe and rate us 5 stars. Also, share with a friend. If you do, who knows, there might be a Backtable hoodie in your future. If you have questions or comments, DM us. We're @_BacktableIND on Instagram, LinkedIn, X, TikTok, and Blue Sky. Backtable is hosted and produced by myself, Anish Parikh,
And Ruchika Talwar.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and we'll see you next time.